Hello and welcome to this special ACR preview podcast, which is brought to you by the Lupus Forum. My name is Ed Vittel. I'm at the University of Leeds in the UK, and I'm the chair of the Lupus Forum. And today I'm joined by two of my esteemed colleagues, both from the USA, Professor Vibeke Strand, who is an adjunct clinical professor of immunology and rheumatology at Stanford University School of Medicine, and Cynthia Aranow, who's a professor of medicine at Hofstra University and director of the Clinical Autoimmunity Center of Excellence at the Feinstein Institutes for Medical Research in New York. Welcome to both of you.
Thank you.
Thank you.
So in this podcast, we're going to discuss what we're looking forward to at this year's ACR. And this year, there is a lot of lupus content. We've captured my chair's highlights in the highlights brochure, which is available now on the Lupus Forum website. And you can find some additional key highlights from our discussion today from Vibeke and Cynthia on a slide at the end of this recording following our discussions today. Between us, we've identified more than 100 abstracts across the conference, which cover a wide range of key topics and therapeutics. In this discussion today, we've tried to bring those together into themes, so you can look at the interesting trends and orientate yourself to what you want to see. And as always, if you also want to be informed about key abstracts for rheumatoid arthritis, psoriatic arthritis, and axial spondyloarthritis, then you should also have a look at the highlights brochures and preview podcasts for these diseases over on the Cytokine Signaling Forum. So, Vibeke, could I ask you to start to kick us off and tell us what you're looking forward to most at this year's Congress?
Well, it is very interesting. I think there's a lot of new things, and there's some that we are gathering quite a bit of information about. There's a late breaker, number 17, about afimetron, which is a new TLR7/8 inhibitor from BMS. And what we see is some positive data from a phase 1b trial in cutaneous lupus with the class A. And so that should be exciting. And I think we know there's another TLR7 inhibitor that is just starting. So that may be a mechanism we should follow.
Yeah.
There's a great deal about CAR T cells. Yes.
I was just sorry to interrupt. I was just going to say that both those TLR7 therapies, I really started watching them after that paper from Carola Vinuesa's group came out in Nature Medicine, in Nature last year, where she showed this variant in TLR7 that was enough to cause lupus on its own, and it works entirely by double negative B cells. So it's absolutely fascinating to see mechanism identified and then two therapies.
You know,
I agree.
The other really important thing about this abstract is that we've been hearing for years from our derm colleagues that, you know, the drugs and interventions that we're looking at are in general lupus, you know, who happen to have some skin disease. And what was really neat about this is that we're now looking at patients who distinctly have CLE, cutaneous lupus, who may or may not meet full ACR or ACR-EULAR criteria. So, I mean, I think that this is an important advance in terms of just CLE.
Yeah.
I agree with you. As a matter of fact, the OMRACT organization with lupus is working on also having a subgroup for mucocutaneous lupus for precisely that reason, because we need different outcome measures in those patients.
Yeah, absolutely. Yeah.
So there's a great deal about CAR T cell therapy in lupus. It was exciting at EULAR, and it continues to be even more interesting here. We have a lot of data from Georg Schett's group, who have treated now 15 patients, 9 with lupus, 3 with antisynthetase syndrome or inflammatory myopathy, and 3 with systemic sclerosis. Interestingly enough, most of them have continued to have treatment-free remission, although only some have expressed as long as 1 to 2 years. But based on the abstracts at this meeting, there seems to be really good outcome measures. There's a relatively low incidence of cytokine release syndrome, generally grade 1 or 2, treated with tocilizumab, little to no ICANS. And interestingly, at this meeting, vaccination responses have been preserved, at least in the Schett group with lupus. There's a new abstract by Novartis, a late breaker, as well as we've got data from Cabaletta and Kyverna. And so we know that quite a few companies in the US are now pursuing this effort. That should be very exciting.
Yeah, I totally agree that, when the first publication came out last year from Schett and his colleagues, it almost seemed too good to be true, right? And now, we're beginning to hear about sustained responses. We heard that, patients went into complete remission, that autoantibodies went down, protective antibodies didn't. The vaccine responses are fascinating. I think that this becomes, more and more promising as we look forward to, okay, how are we going to treat our patients and possibly get them into long-term remission?
Yes.
I think it's exciting, but I also think that it may not be all lupus that is treatable by this mechanism. That we know the genetics of lupus, the mechanisms of lupus. Some of it is not innate. Some of it's not even in the immune system. And whether resetting B cells is enough for everyone. But I do think it'll be right for some patients.
Yeah, I think it at least what we're learning so far is that by and large, it will be the refractory patients, those who've failed a lot of therapies, because the B cell depletion is profound, although it may not be forever, as we've already learned. And it's interesting to see what we're learning about that with these individual patients with quite a bit of heterogeneity. So we'll just have to learn.
Yeah.
Well, there's also exciting new data with the TYK2, deucravacitinib. We know that it's approved in psoriasis, has positive data in psoriatic arthritis, and a nice positive phase 2 study in lupus. And what we've seen now from that trial is sustained responses by LL-DAS and even CLASI 50 responses, and also improved PROs, which are quite nice to see. What's also important is that there appears to be an interferon 5 gene signature that may be a predictive biomarker for this agent. And that would certainly be a positive, because I think we're all looking for those types of biomarkers in trying to select patients for these therapies.
Yeah, in looking at the interferon gene signature, it's really bringing us a step closer to precision medicine. It's like, which drug are you going to use for which patient? And if we had some good prognostic markers, and we're not there yet, but this is just one step closer and really interesting.
And the other thing that I thought was interesting, there's a few TYK2 inhibitors in development, aren't there, of which deucravacitinib is the most advanced. Although on one hand, people say, despite the name, TYK2 is just another JAK. But on the other hand, actually, it is felt that it is quite functionally distinct in exactly what it does, which cytokines it works on, and therefore hopefully also on the safety profile, at least from what we've seen in phase 2.
Yeah, well, I think that may be true specifically for deucravacitinib in the context of how it binds, which makes it selective for TYK2. There's also brepocitinib, which has got a JAK1 effect. And so we'll have to see how that compares as it moves forward, as well as with other TYK2s that you mentioned. There's also the SLEEK phase 2 data with upadacitinib 30 milligrams, and it was also studied in combination with a BTK inhibitor. And after an analysis, they continued the high dose UPA and the high dose BTK UPA and took that through to the endpoint. And essentially what they found is that basically most of the effect, if not all of it, is due to upadacitinib and not to the BTK inhibitor. And so they're moving into phase 3 trials with upadacitinib at that 30 milligram dose, although it may be that after they've treated, they will look to do a step down to the 15 milligram. At any rate, there's some nice B cell markers that appear to indicate the mechanism of action of upadacitinib in this population. So we'll have to stay tuned and hope that the phase 3s are going to be positive after a good phase 2, similar with deucravacitinib.
Yeah, the upadacitinib, it's great to hear that seems effective and it's going through to phase 3. But one of the biggest surprises in recent years is that none of the BTK inhibitors has helped. And I really would not have expected it. I have to say, I really thought they would work. But we've had we had 2-3 trials now that none of them really seem to be showing any efficacy.
Yeah, I agree that that's been really surprising and unexpected. But there's been either they haven't worked or they haven't added anything to the result of studies.
Right.
Going from phase 2 to phase 3 though is always sort of problematic, and I am really, really hopeful because the UPA data looks really amazing, but there have been too many trials that as I've gone from phase 2 to phase 3, and most recently with Barry, it just didn't have an effect when it was done in a larger study. So fingers crossed, and maybe this will be the charm.
Yeah.
We can hope so, because we certainly could use an oral agent, another oral agent. At any rate, there's quite a few abstracts about belimumab, but I think we know belimumab pretty well. We've used it for 11 years. It has a nice safety profile, but this is a nice pediatric study, which essentially confirmed in about 25 patients that the PK/PD that we see in adults is similar in kids. And that will be a very useful therapy for kids with lupus. So hopefully that will be another additional indication for belimumab.
Great. So I think after that's a perfect bridge actually with belimumab, a treatment that we're using now, to go over to Cindy, your selection of abstracts, where you try to focus rather than on new agents that are in clinical trials, to focus on abstracts and talks that tell us about something we can do in the clinic right now. Is that right?
Right. So precisely. So, I usually go to these meetings in addition to trying to catch up with colleagues and former trainees to learn about the new medications, but also what can I take home with me that might affect my treatment of lupus either now or in the near future? So there are a number of abstracts in terms of treatment of lupus nephritis I think it was a Tuesday session. And one was an abstract looking at the effects of high-dose corticosteroids, which is what we use conventionally, versus low-dose corticosteroids. And this is looking at placebo data from completed lupus nephritis studies. So I think that this challenges our what we want to do and what we've been doing. There's another abstract in this session that looks at Cytoxan regimens for lupus nephritis and comparing the old conventional NIH high-dose regimen to the Euro-lupus regimen. And as we know, using the Euro-lupus regimen, there is much less exposure to this very cytotoxic agent. And this is particularly interesting to those of us who treat a large number of patients of African ancestry, because the initial studies that were done of using the Euro-lupus were predominantly done in a Caucasian population. So I'm really interested in learning more about that.
And those two are really those are really topical subjects, because the EULAR guidelines just came out last month. We did a podcast on it. I was a member of it, and those were two subjects that caused a lot of debate. One is, people, like you say, there are some people who say use Euro lupus for everyone. There are some people who say in some situations you should use the higher NIH dose. And essentially the guideline still includes both options. I think to have a talk where some experts will explain how to decide would be very helpful. And steroids, everyone's working harder and harder to say drive it down, use less, taper it when you can, but there's still, I think, some concern about a couple of recent papers that have suggested tapering too much may lead to flares.
And there's a third abstract in this session that is also really timely and also relates to the guidelines, and that's looking at therapies with or without voclosporin. So, it's comparing the ARMS trials to the phase 2 Aurinia trial, and looking at, in the ARMS, it was high dose steroids, high dose 3 grams of MMF, versus the Voclo trials that use lower steroids, lower MMF, but did add Voclo. So, I think that each of these abstracts are going to teach me something, I hope, that I'll then take home with me.
Absolutely.
So I really like this session as I took a look, and there's another abstract in this session that I think is a wake-up call to anyone who is treating lupus nephritis, because we're very used to looking at urinary protein creatinine ratios and looking at the response to proteinuria, and if there's a response, patting ourselves on the back and saying, hey, we've done a good job. And there's a abstract that looks at renal damage, loss of renal function after 3 years after initiating therapy, and compares the urinary protein creatinine ratio to looking at a number of urinary biomarkers 6 months and 12 months after initiating therapy, and then looking at what happened 3 years later. And I think this abstract raises some really important questions going forward as to how are we best going to identify the patients that perhaps need more aggressive therapy, that perhaps we should be changing therapy. Do you think that this is an important abstract to think about as we go forward in our treatment of lupus nephritis?
As we have more options for lupus nephritis, we get more questions, and having too many therapies to choose from is a good problem to have. But then we have to decide when we're going to use them. How do I know whether what I've done has worked? When do I escalate? When do I change horses? So it's very timely to have this session, I think.
Well, we need to remember that it took us a long time to get a functional outcome measure for lupus nephritis trials. So I don't think we're going to, shall we say, give up on it yet. But I have to agree with you. I'm not sure it's really the way to follow patients serially. It's probably better to look for a response. And usually there we have a time frame. And we tend to monitor our patients a little bit more patiently when they're not in trials.
I think that's true. Absolutely. Right. So there's a session that I'm really interested in seeing on Sunday, which is 12S111, and that's lupus prevention and disease modifying anti-lupus drugs. And there are 3 lectures that are going to be presented in this session, but I'm particularly interested in the second lecture on disease modifying drugs in lupus. And this is a relatively new concept that was first proposed in a paper that was published in Lupus Science and Medicine last year. And the thought is that we should be looking at medications at 3 points in time: at the beginning, then at some point in their first 5 years, and then looking after 5 years, and looking to see if they prevent or slow damage, which is really important, seeing if they minimize disease activity, and importantly, as we've been talking about, do they avoid glucocorticoid and other medication treatment-associated toxicities? And I think that these concepts are key as we're thinking about long-term approaches to chronic disease. And I'm really interested in hearing more about this and learning more.
Agree.
So there are a couple of abstracts on another agent that's beginning to receive a bit of attention in lupus. And these are the SGLT2 medications, this serum sodium glucose cotransport 2 inhibitors. And we know that these are efficacious in diabetes, not only to reduce blood glucose, but in terms of cardiovascular and renal outcomes. And in fact, a recent paper that was highlighted in the monthly Lupus Forum did look at these inhibitors in a strain of lupus mice. So importantly, this is a non-immunosuppressive treatment approach, because so many of the medicines that we use suppress the immune system, give our patients more risk for infections. So there are 3 abstracts looking at SGLT2 inhibition in the ACR coming up. One is looking at adverse events in patients with rheumatic disease and diabetes. Another is looking at efficacy and adverse effects of these inhibitors compared to dipeptyl peptidase 4 inhibitors in lupus. And there's a third abstract from Hopkins looking at the potential benefit of SGLT2 inhibition in lupus. So, my renal colleagues have been talking quite a bit about these drugs, and I'm really interested in learning more about the preliminary observational data in lupus.
Yeah, I did the lupus nephritis webinar on the forum a couple of weeks ago with Brad Rovin, Liz Lightstone, and Maria Dalera, and we were all saying that these drugs seem absolutely magical in the things that they can do for lupus patients on top of immunosuppression, and maybe even with some immunosuppressive effects. But there has been at least a remarkable lack of data that's actually specific to SLE. There's a lot of data for other renal diseases, other proteinuric diseases. And then we sort of said, well, we all do nephritis clinics. Who of us have given them to our patients? And we all had. So it just shows you the disconnect. We all want to use them, and we're all crying out for evidence to guide what we're doing.
Mm-hmm. So there were an additional 2 non-pharmacologic abstracts that I'm really interested in, and they're related to questions that I'm frequently getting from my lupus patients. So the first is on the gut microbiome, which everybody is talking about. And these are the bacteria that cohabitate with us and live in our intestines. So Greg Silverman and his group have been studying the microbiome in lupus for some time now. And they've previously shown us that there are differences in the microbiome in lupus patients compared to that of healthy controls. So they have an abstract that is looking at lupus patients longitudinally, particularly at patients with lupus nephritis, and what he refers to as blooms or expansions of a particular bacterium, Rhumacoccus navarium, which I'm going to mispronounce, in patients with flares. So I'm really interested in learning about this as it begins to associate the microbiome, gut permeability, and perhaps some new pathophysiologic mechanisms in lupus nephritis. So, this is something that, is not going to directly answer questions of our patients, but people and patients are interested.
They definitely are.
Yes, they are.
And then there's another non-pharmacologic abstract, which is a mouse study, but it involves intermittent fasting. And so many of my patients are asking me about nutrition, but particularly about intermittent fasting. So this was abstract 2446, and it looked at intermittent fasting in the MLR-LPR mouse models, and then looked at the effects on cognitive function, microglial activation, the nerve cells of the neurons, as well as the blood-brain barrier. And intermittent fasting did have beneficial effects. So it's not going to have any direct applications to our current treatments, but I think it's really interesting and something that we're going to very likely be hearing more about going forward.
And we're currently writing a new British guidelines for the management of lupus, and so we obviously have patient representation on our board that's doing it. And one of the things that came up loud and clear is patients want to know, what can I do for myself? What should I do with my diet? And we all said, we don't know. So it's like you say, people ask, people are desperate to know, and the evidence just isn't there.
Yeah, and cognitive function and brain fog is such a common symptom in my lupus patients, and I think that, this is actually sort of interesting in that there may be something that a patient can do that might actually have an effect.
Yeah, it's going to be fascinating. So I'll definitely be going to that one. So I'm going to finish up by going back to new therapies in trials, and what I decided to focus on the ones we've heard about CAR T therapies, but I had a look at B-cell monoclonals because it remains a very interesting field. So where to start? So firstly, I think we've heard a few times over recent conferences about obinutuzumab. So this is like a next generation CD20 after rituximab, and it's a type 2 CD20, which is more potent at B-cell killing. It's in 2 phase 3 trials in lupus nephritis in non-renal lupus. But there's a couple of extra bits at this conference. There's an abstract that I've authored with Roche Genentech about B-cell return. So we know early depth of depletion is important, but B-cell return can occur at variable rates. And that didn't seem to be too important for some longer term efficacy and safety. And then there's another one in the nephritis data. It goes back to your point, Cindy, about, that is proteinuria alone adequate as an endpoint? And I know we use it, that's how we license drugs, but people want to know, does that also translate to less renal failure, less steroid use, these kind of harder, more meaningful clinical endpoints? So that's what they're analyzing there, and I think it's important to see this. There's a last one, a non-pharma study on obinutuzumab, which is something I'd also looked at a few years ago, which is that we use a lot of rituximab in my clinic, but what you get is a lot of people get anti-drug antibodies in lupus, and it stops working. And actually, in those people, we found if you switch them to obinutuzumab, it seemed to restore all of the efficacy. And there's a French study in 50 patients saying a very similar thing, which is quite relevant to practice right now, because obinutuzumab is available now off license.
Yeah, very important. We've always said that you need to use an immunosuppressive with rituximab, but that still doesn't abrogate the immunogenicity.
And it's something to do with lupus and Sjögren's who get that problem, not rheumatoid and ANCA, as far as I can see. Yeah. So then there's a few abstracts that are getting into the concept of BAFF inhibition and B-cell depletion as a kind of combination. So there's an academic there's a couple of academic studies that have looked at this. One is Beat Lupus done in the UK, and one is the Calibrate study. And these are 2 studies where they took rituximab treatment and then followed it up with belimumab treatment. And the Beat Lupus study of those did meet its primary endpoint in terms of lowering antibody titers and also preventing flares with the combination compared to rituximab alone. But there's an interesting story been emerging out of this for the last year that it surprised me a bit. So the primary endpoint in Beat Lupus was double-stranded DNA. titers. But they subsequently did a lot of biomarker analysis. And one thing that's really coming out of their results is that IgA2 double-stranded DNA antibodies seem to be the ones that really matter. So IgA antibodies, pneumally associated mucosal immunity, if you've got them, you're more likely to respond to that combination, and the level of reduction in them seems to associate with how well you do. And in this abstract, they've then extended that study by taking the samples from the Calibrate trial and showing the same thing.
Mm-hmm.
So it looks like it's real, and it's a slightly surprising result, but one that's good. I think there may be potential to personalize therapy a bit based on that.
Yeah, I mean, I agree that the results are sort of surprising, but what it's telling us is that there may be a subset of patients within the huge heterogeneity of lupus that do respond very well to this combination therapy, because the clinical trials just don't seem to bear that out. In addition to the Calibrate, there was a GSK's Bliss Believe, and again, using very stringent endpoints that failed to meet its primary endpoint. There's also the Symbiose trial, right? That looked at lupus nephritis but that was not controlled, but in which there were, it seemed that there were very positive results. So I think that this is still a very interesting approach to trying to treat severe lupus.
Absolutely. And then if you like the combination of B-cell depletion and BAFF inhibition, then the drug is ianalumab, a Novartis drug. But this is an interesting one because it's a monoclonal antibody that targets the BAFF receptor, which most mature B cells have. But it doesn't just block signaling through the BAFF receptor, it also kills the B cell. So you may get both effects helping to block the pathway. And there's a couple of abstracts at this conference. So firstly, there's the phase 2 randomized controlled trial in the Tuesday oral session, where they show there's potent B-cell depletion, clinical response, less use of steroids, and it's progressing to phase 3. There's actually a Sjögren's study as well presented at this conference, the same molecule. And there's also a poster about ianalumab, where they show that as well as killing B cells and inducing clinical responses, there's also an association with reductions in interferon gene signature, which is perhaps not what you would have gone for. But just like you said, Vibeke, it's about, we need these biomarkers to tell us who for which drug, and how to know when the drug's working. And then lastly, just on my B-cell abstracts I looked at, is that there continue to be some abstracts about new ways of inhibiting the BAFF system that look interesting. So, of course, as you said, Vibeke, we're used to belimumab, and we continue to get more and more good data about it every year. But the thing about belimumab is it only blocks BAFF. And this is a system that includes 2 ligands, BAFF and APRIL, and they bind to 3 receptors that have a different affinity for BAFF and APRIL as the B cell goes through its life cycle. So the new generation of BAFF blocking drugs are designed to block both BAFF and APRIL more effectively. One of those is the Alpine drug, povetacicept, and they've got a poster where they actually did some translational science to back up the proof of that principle. So in other words, to show that both BAFF and APRIL are overexpressed in lupus, and that in vitro povetacicept could block both of them, and showed in B cells in vitro that's a better way of inhibiting B cells. And then the other one, I'm only going to say it briefly because this is rheumatoid arthritis, not lupus, but we've all heard in the last couple of conferences about telitacicept with seemingly quite impressive results in lupus. And they've actually got an abstract here with the same drug in rheumatoid arthritis, which couldn't be belimumab right at the beginning of its development wasn't really effective in rheumatoid arthritis, but that's being claimed here.
It's very interesting because povetacicept is arguing that it actually binds APRIL even more efficiently than telitacicept. And of course, we have this nice data from telitacicept in lupus, but only from China. We've really never been able to dig into the data in great detail. And so I was surprised also to see an RA study and was hoping to see more lupus work. But I think the point is targeting BAFF and APRIL together really is a much more effective way of targeting the B cell effects in lupus.
Yeah, so the whole B cell story could be summarized. Whether you want to deplete them or whether you want to block BAFF, it's always hit them harder. It seems to be.
And it may be safer than depletion too. So
maybe, yeah, it may.
But it remains to be seen, in terms of toxicity, because belimumab toxicities are fairly low, and I wonder what you see when you're blocking both BAFF and APRIL.
Not only that, but you are losing immunoglobulin levels, and so that has to be monitored. So we'll have to see, but it's always another mechanism which is helpful.
Absolutely.
To understand.
Good problems to have. So that's all we have time for, folks. I hope you've enjoyed this preview. The Lupus Forum has plenty more ACR content planned as the Congress gets underway. For a condensed overview of the most important abstracts presented each day, be sure to have a look out for our daily highlight videos. As always, after the meeting, the three of us are going to get back together again to broadcast our ACR Congress Review webinar. And in that broadcast, we're going to have a talk about what we saw, the abstracts we've just been talking about, what we learned, and maybe anything we didn't expect that came out of the conference that should help you to catch up on what you missed. Don't forget to have a look at the website, have a look at the Lupus Forum, that's lupus-forum.com, and download our ACR 2023 highlights brochure, which has got all the details of all the top abstracts. And all that remains for me to say is enjoy the Congress.